Hello, everyone. I want to welcome you all, along with Carissa Charles from Heart Valve Voice US, to our webinar on Could it be my heart valve disease in women? We are doing this webinar because we feel it is so important to do awareness and education around Heart Valve Disease Awareness Day, which is actually Saturday. So we didn't bring you all in on a Saturday for this, but we wanted to make sure that we acknowledged this important day and that we had some educational programming for you available. For this webinar, our moderator is Selena Gore, the CEO of WomenHeart, and we have panelists Crystal Zeller, who is a patient living with heart valve disease, Dr. Erin Michos, the Director of Women's Cardiovascular Health at Johns Hopkins, and Carissa Charles, again, who you see here, Executive Director at Heart Valve Voice. Just a few things before we get started, I wanted to tell you about WomenHeart and Heart Valve Voice. So WomenHeart is the National Coalition for Women with Heart Disease, and we are a nonprofit organization. Our mission is to improve the lives of women with or at risk for heart disease while fighting for equity in heart health. WomenHeart is a leading voice for all women in raising awareness of the prevalence and risk of heart disease in women. Our pillars are support, education, and advocacy, and much is provided through the WomenHeart champions who are extensively trained women with lived experiences of heart disease. Heart Valve Voice is a patient advocacy nonprofit organization, and they provide patients with a united voice to improve health for people living with heart valve disease by advocating for early detection, meaningful support, and timely access to appropriate treatment for all people affected by heart valve disease. Heart Valve Voice works with people living with heart valve disease, clinicians and other experts, and other patient service and advocacy organizations to identify barriers to improving health for people living with valve disease, and they advocate for change to enhance health. I would like to thank our sponsor for this educational opportunity, and that is Medtronic. And I wanted to let you know, all of you will be in listen-only mode. If you can use the Q&A feature for questions, that would be really helpful at the end when we take time for questions. And also, always consult your healthcare providers and professionals about your specific condition and treatment options. Okay, now without further ado, I am going to turn it over to Dr. Erin Michos, and she will be presenting her slides.
Get it up here and let me get my pointer. Okay, great. Thank you for inviting me to be here to talk about cardiovascular disease in women, which is a really broad topic. So most of my talk is going to be really focused on aortic stenosis. I do have some consulting relationships. First I'm going to start just out broadly about cardiovascular disease. So you may have seen these statistics from the American Heart Association. So in the 80s and 90s, cardiovascular disease mortality, cardiovascular deaths were declining in men. The first statin came out in 1987, and there was an attention to reducing smoking and treating blood pressure and cholesterol and prevention in men. And their death rates were going down, but women were ignored. They were not given statins, they were given hormone therapy, their cardiovascular risk was ignored. And for a while, more women were dying every year of cardiovascular disease than men. Until this came to attention, and around the year 2000, there were some important initiatives, the first prevention guidelines in women, things like the Go Red for Women campaign from the American Heart Association. And then there was a dramatic decline in cardiovascular mortality in women and a continued decline in men. And this is why I love being a preventive cardiologist, because we do think about 90% of cardiovascular disease is preventable. But unfortunately, we all need to be really alarmed about what's been happening since 2010, that we're no longer making progress in reducing cardiovascular death. We're no longer even stagnated, but cardiovascular mortality is back on a rise in both women and men due to epidemics of cardiometabolic diseases like obesity and diabetes. Now, these are absolute numbers, but if you're going to look at rates of change, actually the fastest growing rate of increase is in middle-aged women. which is a age I belong to. It's a time in a life when women often have dependent children and aging parents. They may have a spouse, a partner, a career, a lot going on where they're all focused on everyone else's health, but not their own. And it's so important that women know their risk factors for heart disease, and particularly around the menopausal transition, there's a lot of worsening of cardiovascular risk factors. So I'm going to be talking about aortic stenosis, which is more common in older adults, but is really important attention for all cardiovascular disease risk factors. Because as I mentioned, we think about 80 to 90% of cardiovascular disease is preventable. And so I like this framework from the American Heart Association about life's essential 8. These are 8 modifiable factors that we can all do to reduce our cardiovascular risk, such as eating a healthier diet, increasing physical activity, not smoking, getting adequate amounts of good sleep, managing a healthy weight, controlling cholesterol. And this is a big one. About 60% of attributable risk for heart attack is due to cholesterol. And women just do not get their cholesterol treated or controlled like men do. And they're very undertreated for statins. And so this is a major risk factor I talk a lot about in other talks. It's important to manage blood pressure. Hypertension is another big risk factor for heart disease, and managing blood sugar. So in addition to these traditional risk factors, I just want to point out that women also have unique risk factors throughout their lifespan that men do not, related to these female specific factors, like having polycystic ovary syndrome, having had a history of a complicated pregnancy from preeclampsia or gestational diabetes, or going through menopause early. These all increase cardiovascular risk in women. And so, as part of risk assessment, it's really important that we not only screen for these traditional risk factors like blood pressure and cholesterol, but also ask women about their reproductive history, which also may identify women at higher risk. And so in our guidelines, a lot of guidelines focus sometimes on these 10-year risk scores about risk of heart disease in the next 10 years, which I think is really misleading, especially in younger women, because really we want to think about a life course approach and not just prevent heart disease in the next 5 years, but over the next 5 decades. But additionally, there's a lot of factors that are not in those 10-year calculators that increase someone's risk for a cardiovascular event. We call these risk enhancing factors. So it's important that these are screened as well, such as having had a family history of an early cardiovascular event in a first degree family member, having a chronic inflammatory condition like rheumatoid arthritis or lupus, which are more common in women, having had, preeclampsia or early menopause, having high cholesterol, being of South Asian ethnicity, having kidney disease or metabolic syndrome, or if these measures are blood tests are checked, having high levels of a lipoprotein called lipoprotein little a. This is linked not only to atherosclerotic cardiovascular disease, but also aortic stenosis that we'll be talking about, or having high levels of inflammation in the body by a C-reactive protein. So if these factors are present, this puts individuals into a higher risk category that would favor more intensive prevention, such as the use of a statin. So when I talk about cardiovascular disease, this is a really broad term, and I can't cover everything today. I'm really going to be focused on aortic stenosis after this. But just what we're talking about, there's certain types of cardiovascular disease that affect both men and women. The leading cause is atherosclerosis, where there's plaque building up in the arteries over time from high cholesterol. Inflammation can fuel this plaque formation and insulin resistance. And so when this plaque or atherosclerosis is in the heart arteries, it's called coronary disease. It can be in the brain arteries and lead to stroke, and it can be in the peripheral arteries. Both men and women can have issues related to different types of arrhythmias and heart failure, as well as valvular heart disease, which we'll talk about more. But I also want to point out that there's some types of cardiovascular disease that are more common in women or only experienced by women. And this includes microvascular angina or chest pain, ischemic disease related to insufficient blood flow, but not due to blockages in the large arteries, but dysfunction in the heart's smallest arteries. This is more common in women. Vasospasm, where the heart arteries can have a spasm as opposed to a plaque blockage. That's more common in women. Heart attacks related to a dissection, a spontaneous coronary artery dissection, or SCAD. This is 90% female predominance, where the heart attack's not due to atherosclerosis, but due to a tear in the artery. conditions called stress cardiomyopathy, where a sudden, very stressful event can lead to a catecholamine surge that can stun the heart's function, lead to a weakening of heart. That's more common in women. Women can have a heart failure related to pregnancy, again, only affecting women. And women can have a type of heart failure called heart failure with preserved ejection fraction that's more common in women than men. All right, so I'm going to focus now on valve disease, and that could be another whole hour-long talk because there's 4 heart valves, and each valve, if it could potentially have a problem with stenosis, where it doesn't open very well, or regurgitation, where the valve leaks, or there can be mixed valve disease, where the valve both has problem with opening and leaks. Now focusing on aortic stenosis. So the aortic valve sits here. It's one of the 4 main heart valves in the heart, and it's located between the left ventricle, or the heart's main pumping chamber, and the aorta, which is the major artery out that takes blood away from the heart, to the brain and all the other organs in the body. And this is one of the most common and most serious valve disease. It's a progressive disease where the valve, which normally has 3 leaflets, has inability to open, where there's a narrowing or restriction to the opening. And because less blood is coming out of this valve, the heart has to work harder. It can get thickened and enlarged and lead to heart failure. And also because of decreased blood flow going into the aorta, people can have, dizziness and passing out, or chest pain, or other consequences of having insufficient blood flow. So first, let's go over some risk factors for aortic stenosis. So age is the most significant risk factor. If you live long enough, over time, wear and tear of the heart over decades, the valve can get calcified. And so age is one of the biggest risk factors. Other risk factors include some of the same risk factors that can lead to plaque in the heart arteries can also lead to valve problems, and that's having high blood pressure, high cholesterol, diabetes can all lead to plaque building up on the valves as well as inside the arteries. Now, some people are born with an aortic valve problem where their heart, instead of having 3 leaflets, they were born with only 2 leaflets of the aortic valve. And because the valve was never formed right from birth, the valve can wear out more quickly, and they develop aortic stenosis, sometimes at much younger ages. Rheumatic fever, we see less of this now that we're treating strep infections, but individuals who've had rheumatic fever, that infection, that damage can damage the valve tissue and lead to aortic stenosis. If individuals have had radiation therapy to the chest, like from a lymphoma, or if they've had left-sided breast cancer and had radiation, that radiation can damage the valve and lead to aortic stenosis. Patients with chronic kidney disease, which often has increased calcium overload and inflammation, those same processes can damage the heart valves. Genetics, some people, because of their genetics, are more predisposed to get aortic stenosis, and smoking, being a very inflammatory state, can lead to aortic stenosis. So those are the risk factors, some of which are preventable, although some are not. So aortic stenosis is pretty prevalent. If you look at adults over the age of 75, more than 13% of older adults have aortic stenosis, and the frequency increases with age. Now, when we talk about severe symptomatic aortic stenosis, where the stenosis is severe and actually causing symptoms, that's about 1.6 million adults over the age of 65. Now, about half of the individuals in the US who have aortic stenosis are women, so this does affect women similarly to men. So, aortic stenosis is a progression. Some people may only have mild aortic stenosis, so enough blood is able to get through the valve, but it can progress all the way to severe, where the valve is just a pinhole and not opening. And this can be progressive. And so many patients with aortic stenosis don't really have noticeable symptoms until the blood flow is really reduced. Those who are born with an abnormal valve may not even realize they have an abnormal valve until they get to an adulthood and start getting to have symptoms. Well, this is 1 to 2% of the population have a bicuspid valve, so it's actually the most common congenital abnormality. So lots of people with AS don't even have symptoms, but if you have symptoms, what they may look like? Well, one could have chest pain caused by exertion, because if less blood is able to get through the valve when someone's the heart has to work harder because of exerting oneself. If it can't provide enough blood flow, you can get exertional chest pain that's relieved with rest. Trouble breathing, feeling short of breath, feeling dizzy or lightheaded, even passing out. Having increasing difficulty tolerating exercise, not being able to do what one was able to do, having swollen ankles or feet, difficulty sleeping due to shortness of breath or needing to sleep sitting up because of the high pressures in the heart. It be hard to breathe lying flat, and some patients, with heart failure need to sit up to be able to breathe better, and so that could be a sign of heart failure. Now, this can be really insidious because aortic stenosis can progress like over years, over decades. And so it can be this gradual decline in activity level or on the inability to do normal activity. So people just kind of do less and less and less over time because they're not able to because of aortic stenosis. And so this is why a lot of people are walking around with AS and don't even realize they have it because they've just kind of adapted and start doing less. So how do you diagnose this? Well, first, of course, is understanding some of the symptoms, and your healthcare professional may listen to your heart for any murmurs or sounds. Now, not all murmurs are AS. Murmur just means a sound, so it's not always aortic stenosis. And one paradox I should point out, though, is actually paradoxically, when the aortic stenosis is very severe, there won't be much of a murmur at all. If the valve can barely open, it doesn't actually make any sound. The heart sounds are muffled. And so sometimes the louder murmurs are actually with less stenotic valves. And so this is why sometimes it can be missed in severe AS. It may not actually have a loud murmur. So if AS is suspected, how do you make the diagnosis? Well, the diagnosis is primarily made with imaging, an echocardiogram and ultrasound of the heart, where by ultrasound, so no radiation, you can take pictures of the valve and the heart function. It tells us how severe the AS is and how well the heart is functioning. And while that's the primary test, sometimes there can be incomplete information about the severity. It can be a little uncertain how severe things are. And sometimes we, as cardiologists, order other tests for patients, including CT scans to look at the calcium on the valve. Sometimes patients need a cardiac catheterization to measure the pressures in the heart, blood tests to look for heart strain, or even sometimes stress tests where we want to kind of see if we provoke someone with exercise, whether we can determine whether there's more of a problem with the valve than we realize at rest. So aortic stenosis can be progressive and quite debilitating. As I mentioned, people can have decreased exercise tolerance, chest pain, or even passing out. Now, once somebody actually develops these really severe symptoms, the worrisome symptoms are heart failure, chest pain, or fainting, severe symptomatic AS. If one does not get their valve replaced, the prognosis is very, very poor. And so this is why we'd like to identify it before we get to this severe symptomatic phase. But once it's identified, it's urgent that we address the valve problem. And severe symptomatic AS does have a untreated, has a poor prognosis, often similar prognosis as certain metastatic cancers. So when it gets severe and symptomatic, it's really quite a medical emergency, urgency. So we'd like to identify it before we get to that severe symptomatic stage so we can follow patients, and early treatment is the key to preventing the failure of the heart. If the aortic stenosis is only mild to moderate, your doctor may just be following this with echocardiogram and yearly exams and imaging to kind of follow it. Although there's no medicines to necessarily reduce the stenosis when it's present, we want to treat things to prevent progression. So treatments to like statins to lower cholesterol, treat blood pressure can help slow progression. And then, discussion, if it gets to be severe, do you need a new heart valve? And this is made, with a team-based approach with often a cardiologist, a heart valve team, including, often an interventional cardiologist, a surgeon to really kind of decide, does the valve need to be replaced and what's the best approach? Traditionally the valve, when it needed to be replaced, was done by surgery, and we still do that in certain cases, especially younger individuals who might need a mechanical valve that's going to last them their whole life. But now we have options to replace the valve in a less invasive way through a catheter-based approach, and that's particularly what we often do in older adults who are not good surgical candidates, and it's really become the mainstay of treatment. And that's what's TAVR, called transcatheter aortic valve replacement. Sometimes it's called TAVI, transcatheter aortic valve implementation. And so this is a minimally invasive procedure where a new valve, aortic valve, is inserted on a catheter. Through entering an artery, the interventional structural cardiologist passes a catheter that has the valve on the end of it and directs it up into the position, and either the valve, through either self-expanding or balloon expanding, it essentially pushes the old disease valve out of the way, and the new valve is put in place where the old valve was. So just like if you might have familiar with having stents put in your heart arteries, this is essentially a stented valve. So it's a stent that's put in a valve place. And so the advantage of this is that there's no open heart surgery. This is all done through a catheter. So because the chest wall doesn't have open heart surgery, there's less trauma to the chest and heart muscles. There's less risk of infection. Patients recover faster. They often go home the next day. And there's even some protocols where maybe low risk patients could even go home the same day. But it's much shorter hospital stay than open heart surgery, and patients recover faster and get back to their activities faster. So it was really a game changer in how we treat aortic valve disease. And so there's a lot of factors that go into what types of valves, and that's all part of discussions with the team. Again, younger individuals who have a lot of decades ahead of them likely will be recommended from our surgical valve. SAVR stands for surgical valve, often mechanical valve, because they have a lot of decades ahead of them. But older adults, we generally always do a tissue valve, and particularly older adults now who are not good surgical candidates due to age, do the transcatheter valve replacement. So replacing the aortic valve for AS has really been a game changer. As I mentioned, there's no medicines that can treat aortic stenosis once it's present. It's a mechanical problem. The valve doesn't open and needs a mechanical solution to replace the valve. And so the survival with a valve replacement TAVR is much improved over just medical therapy alone. In fact, since TAVR has been introduced, death due to aortic stenosis has dramatically declined, really improving quality of life of patients, and we think a lot of societal gain. But despite all these advances, severe symptomatic aortic stenosis is still significantly underdiagnosed. There's still a lot of lack of awareness, lack of diagnosis. This is data from Europe, and the undiagnosed patients with severe stenosis, here in the blue, far outweigh the number of patients that actually got valve replacement. So there's a lot of people walking around with AS that don't even know they have it. In fact, it's estimated that less than 50% of patients who have severe symptomatic aortic stenosis are treated. And there's disparities. Women are less likely to get a valve replacement than men, and Black patients are less likely to get a valve replacement than white patients. And there's even regional variations. As interestingly, the likelihood of getting a valve replaced really differs depending on which cardiology practice or part of the country. And so we're doing a lot on the clinician side to try to educate cardiologists, because some are just not referring as much as others. So there's a lot of disparities related to disease, healthcare systems, and patient-related factors. So we want to improve that. So just since this is a women's heart segment, just on the last few minutes talking about differences between men and women with aortic stenosis. So sometimes symptoms can be different in women. Men more likely get chest pain with their aortic stenosis, where women may get more likely be short of breath or dizzy or passing out. Women tend to be older when they have AS than men. And when women have aortic stenosis, there's actually often less calcium, but more fibrosis, fibrotic tissue. Men tend to have more calcium. And then how the heart adapts to this tight valve, women are more likely to get what we call concentric hypertrophy, where the walls equally become thick, or men get acentric hypertrophy, where it's asymmetric thickening of the valve. And then there's some issues with the types of AS. Women are more likely to get something called paradoxical low flow, low gradient AS, where there's actually less flow through the valve, but the gradient, the pressure that was measured on the echo is not that high, but there's less stroke volume, there's less cardiac output coming through the valve. And so this can make it more challenging to diagnose because the classic gradients are not that high and they may underestimate the severity, but there's really still very low flow going across that valve. And then women are just smaller. They have smaller body sizes, including smaller aortas. And so, because women have smaller aortic annuli than men, don't often do as well sometimes with surgical valves because the sewing ring would take up a lot of room. And that's one of the advantages of these stented valves is that you can often use a valve that has a larger area to kind of maximize the valve performance, which can be even more important in women because they're smaller. So this is a quote from Dr. Marin, a cardiologist at Mount Sinai, that I liked. She said, "Heart valve disease is regularly undetected, misdiagnosed, and undertreated in women. Part of this reason is that heart disease research mainly studied men, so a lot of the detection, treatment, and standards of care favored men over women. So we need to do better to reduce these sex and gender disparities." And so Dr. Merriam actually was an investigator in a TAVR trial that enrolled 87% women. And as I mentioned, trials tend to under-enroll women. They tend to enroll more men than women. And so having a trial where most of the patients in the trial were women is really quite unique in this field. So women with aortic stenosis are undertreated. So the diagnosis, as I mentioned, can be more challenging because they may have low flow, low gradient AS. And so this leads to less frequent delayed. Sometimes their symptoms are dismissed because they're not having chest pain. They're just having decreased exercise tolerance. And so women with AS are up to 35% less likely to be treated than men. Now, women in general live longer than men, but if they have severe AS, they have actually a higher mortality than men. So that's why we have to treat AS in women. With surgical valves, women sometimes had worse outcomes because they had smaller hearts and sometimes did a little bit worse with surgery than men. Of course, they did better than no treatment. And even with TAVR, because women are smaller, they may have more bleeding complications related to vascular access. But to get through the procedure, many studies have suggested that women do better after TAVR compared to men long term. So this is 1 year outcome after a TAVR, and these are look at different cardiovascular events, major adverse cardiovascular events, or death or stroke, or death or a heart attack, and really show that women here in the red had less likely to have these outcomes as men. And so actually, when they get through the procedure, women actually may do better with TAVR long term. So this is my last slide, so we can get to here our patient case and our discussion. Just a reminder that cardiovascular disease, so all encompassing, heart disease, stroke, is still the leading cause of death of women worldwide. And it's important that patients understand their risk factors, both those traditional risk factors and those non-traditional factors, as I mentioned, to really understand their own risk and get a personalized approach to prevention. Because really the best intervention is trying to prevent in the first place. And so understanding the symptoms of heart disease and when to seek help. And if you don't feel your concerns are not being fully addressed, it's okay to get another opinion. As I mentioned, even with aortic stenosis, there's a lot of regional variation and even among cardiologists about who gets referred for treatment. So if you don't feel like your concerns are being fully addressed, it's okay to get another opinion. Now, aortic stenosis is very prevalent in older adults. It's still underdiagnosed and undertreated in women. But we have a lot of good new options now. TAVR is getting better and better with new devices and better outcomes, and a multidisciplinary valve team that includes, a general cardiologist, a structural interventional cardiologist, a surgeon, a valve clinic coordinator, a heart failure specialist, imaging physicians and primary care, or all can help come up with the best management plan and treatment plan for an individual patient. So I will end there so we can get to the rest of our program. I look forward to taking your questions later at the end.
Thank you, Dr. Michos, and hello. It's been a while since we saw each other. I would now very much like to invite Crystal Zeller to speak a little bit about her experience. Crystal is a woman living with heart valve disease who has also undergone a TAVR procedure that Dr. Michos just described. She's with us here today to very generously share her heart valve disease story. So, Crystal, over to you.
Okay, back when I was around 50 years old, I had broke my left sinus cavity and had gone for surgery, and they repaired my left sinus. It was broken right here. It was flattened totally. So everything seemed fine and everything. And I think, around 50 at that time. And at 55, I kept getting bronchitis over and over and over again. So I didn't know what was going on. So I went and saw my family doctor, and he wasn't in. So I saw a physician assistant. And she was very concerned because she heard a heart murmur. So she called another doctor in to confirm it. And I definitely had a heart murmur, which I'd never had signs of a heart murmur before. So they sent me to, when I was getting bronchitis and everything, back up a step here, I went and had my sinuses cleaned out, which it was a fungal infection. And they removed it. It grew right back. And they removed it again. And then it seemed like it was okay, but it was never 100% okay. So then, like I said, at 55, they discovered I had a heart murmur, and at that point, they sent me to a heart doctor, and he had did it he did a catheterization on me, and because he thought there might be a blockage or something, which was causing my heart valve problem, and my arteries were clear. There was nothing wrong with them. So then he proceeded to he did a stress test on me, which I didn't like what happened. Then they did an echocardiogram on me, and they kind of felt that I was going to have it fixed. But like he said, the longer I could wait, the better it would be, because the technology is improving so greatly that I won't have to have open heart surgery. So, like I said, I was 55 at that time, and I went and saw him every year for a yearly checkup. I think in the beginning it was every other year I had an echocardiogram. Then after it started getting worse, and I was kind of in denial because I figured I wouldn't have to get it done, and I was going to make it through all this, and I was going to be fine. And he kept saying, "You're going to have it done one day, but you will know when you're ready." And then it was last May or June, I went to see him, and we were both in agreement it was time to have it fixed. And now with the TAVR and everything, it was so much easier. So that's when we started the procedure of doing the TAVR.
Thanks, Crystal, for that. And just to follow up, between the time you were diagnosed with heart valve disease and the time you actually had the surgery, so this is sort of a wait and watch time. As you were monitoring it, what were you going through that ultimately led to you and your doctor agreeing that it was time for the heart valve replacement?
Well, at first it was really nothing. I'm a farm girl. I mean, I throw hay bales, I ride horses, I shovel shit, I do all that stuff. And as time went on, every year it got a little bit worse, but not real bad. But the last 2 years it was starting to get worse. And like I said, probably it was in 2024, like in January or so, I felt it was going to be soon time because I was getting tired. I was having trouble getting my work done. I had to keep pushing through things. I had no energy, but I was still in a little bit of denial that I really didn't have to have it done. But
Yeah.
I did make the mind up that I did have to have it done.
Yeah. Yeah. And it sounds like ultimately you felt like there was a reduction in your ability to live just sort of your day-to-day normal life, and it was time
Oh, yeah,
to do
definitely,
surgery. Yeah.
definitely,
Um,
definitely.
Dr. Mikos, the fact that Crystal was able to catch it early and was being watched meant that the heart valve replacement wasn't emergent. But we know that it's very often that women who have heart valve disease are treated later on in the progression of their disease. Do you have some thoughts on how women might be able to approach, the speeding up of their diagnosis, or sort of the speeding up of the conversation around heart valve disease or the possibility of heart valve disease given a certain set of symptoms?
Yeah, so it's really important for early detection and diagnosis, not because the valve always needs to be replaced right away, as in Crystal's case, but because she got follow-up. So it was identified. She knew what symptoms to look out for. It was a conversation with her doctor. Every year she was getting echoes. We follow people. And so we follow people for signs that the heart on echo is struggling more. And then we ask the patient if they're struggling more. But see, a lot of people don't get that initial diagnosis and follow-up, and they don't get diagnosed till the heart's already like failing. So the idea in Crystal is that they found the time before her heart had failed, and this is okay, this is the sweet spot. We're going to replace it, improve symptoms, but before there, there's too much irreversible damage. And so we don't want to wait till somebody's already, now in profound heart failure at a really extreme stage. So it's really important that symptoms are being recognized. So all of those symptoms that unexplained shortness of breath, chest discomfort, being dizzy, lightheaded, just not being able to do the activities you used to be able to do. This should prompt a cardiac evaluation. And not all cardiovascular disease is aortic stenosis. So in Crystal's case, they were first worried about coronary disease because that's actually one of the leading causes. And so that was important. It was evaluated. She had a stress test and she had a cath. And so it was realized it was not her heart arteries, it was her heart valve. But the important thing was identifying symptoms, a change in symptoms. So what I would encourage patients to be very proactive about, your body, and if something is not right, that your symptoms are not right, to get a thorough checkup. It may not be aortic stenosis, but you need a workup to figure out, kind of what it is. And hopefully you have a good doctor who's listening to you, who's willing to embark on this process. But I also mentioned, if you don't feel that your symptoms are being addressed, and we do know that sometimes women's symptoms are ignored, women are more likely to be labeled as anxious or just deconditioned, or their heart symptoms are not recognized because there's still this bias that heart disease is a man's disease when it's clearly still the leading cause of death in women. So if you don't feel that your symptoms are being worked up or treated, then that's when you might seek another opinion. But it's really important to identify those heart symptoms. That's where it sort of starts. And know your risk factors, because some things, a lot of at least atherosclerotic disease, can be largely preventable.
Yeah, thanks for that. And it sounds like Crystal's lucky in her experience then to be able to have worked with a doctor and not have valve replacement be so emergent. So Crystal, it sounds like when you had your valve disease, your valve replacement, you said that you and your doctor were in agreement. So and that's fantastic, because it sounds like you and your doctor also employed shared decision making, right? Which is, I think, the ideal scenario for any patient. So my question, Crystal, for you is, what information did you have, or were you provided, or did you seek out that made you ready, right, to have the valve replacement? Because, right, like that's not an easy decision for folks to make, but it sounds like by the time you had it, you had all the information you needed, and we're ready to go.
The first thing I would just want to follow up on that, do seek a second opinion. When a doctor tells you you're just getting older, that you can't do it anymore, don't believe them. If you feel that there's something wrong, because I had no chest pain, the only thing I had was tiredness and shortness of breath. And I did seek a second opinion about it, not with my heart doctor, but with my family doctor. But I know someone who supplied me with a whole bunch of the different valves and everything, and I was going through it and everything, and the way I work, the way I'm built and everything else, because I'm a strong girl, I kind of felt the Medtronic valve was a little bit bigger, so that's why I went with the Medtronic valve. So I made a decision to call where I went to a WellSpan place, and I called them and talked to the assistant, and she said that she will talk to the surgeon and see what he has to do. I said, because I'm very active, I ride horses, I bale hay, I mow lawn. My husband died away, so I'm just a one-armed bandit here right now. So anyway, the surgeon an hour later called me. He said, after reviewing all your information, everything, I think he said, I think you'd be better with the larger valve. And then when they put it in, it popped in, it never came out. They put it in one time and done. And he said, the valve fits you perfectly. So, I mean, that to me was a step that I made in the right direction, I felt.
Yeah, no, incredible. And again, this notion of shared decision making is just wonderful. And I love how you're describing, like you really shared with your physicians and your surgeon what your day-to-day life looks like, right? And that is important.
To know that. They really do have to know that.
Yes, absolutely. I'd love to bring Carissa in. Carissa Charles is the Executive Director of Heart Valve Voice US. Carissa, I want to ask, in your opinion, what do you think we can do to raise more awareness among women about the risk of aortic stenosis and valve disease? And I ask that in the context of, I think, Crystal's case is an ideal case, right? In many
Right.
ways, somebody who has valve disease. And she, speaks so eloquently about her being, very much in control of her process from the get-go. So I'd love to hear from you and what you all are doing to raise awareness among women around heart valve.
Of course. So some of the strategies, of course, in Crystal's unique story, she was well informed about valve disease. But I think some of the unique strategies we can employ in women as well as the general population is really developing more awareness campaigns, especially on social media, getting more people aware about the risk factors of valve disease, specifically in women, as well as acting early on early treatment options to decrease some of the morbidity and mortality related to valve disease and increase referrals for treatment of women within TAVR. And specifically what Heart Valve Voice is doing, we have our Ask for Echo campaign that really targets people to understand the risk factors for aortic stenosis, how to move forward in getting a diagnosis and their treatment options, so they are able to make an informed decision with their care team as well. And we really try to target that within women, especially since women are so busy. They are usually the matriarchs of the home. We really want to ensure with that campaign that women are aware of their risk factors and they are able to take care of themselves to seek the next steps.
Thank you. That's fantastic. Dr. Michos, I want to come to you and ask you, you've mentioned many times how, folks really need to pay attention to their symptoms, and for women to know what sort of the more, I hate to use the word atypical, but the symptoms that are more pronounced in women versus men. And you talk about not downplaying, those symptoms, but not to downplay what is involved in having a valve replacement, but what do you see in patients who undergo a TAVR and how it's impacting their everyday life, perhaps, compared to other procedures to treat heart valve disease?
Yeah. So, aortic stenosis, when it gets to be severe and symptomatic, is a very progressive, rapidly disabling disease. And so, it's very important to get treatment because it can change the whole trajectory of someone's life. And with TAVR, it's really been quite advantageous because the faster recovery, because there's no open heart surgery. So we do know that women who go open heart surgery have a little bit worse outcomes than men. They have smaller body size, smaller arteries, smaller valves, and they're more increased for bleeding. Often because when women do need heart surgery, they often tend to be older than men because they kind of present later in life. And so they might have worse outcomes. And so with TAVR, not needing the open heart surgery and often the ability to use a larger valve because women's artery aorta, their annulus is smaller, and the typical surgical valves, you have a sewing ring. And so with some of these new valve types, and they can actually have be useful in women who have smaller annulus. You can get a bigger valve in there for the space. And so people do, they feel often so much better after their valve. They can have, improvement in their quality of life and get back to doing their activities. As you heard in Crystal's case, she got back to doing a lot of the things that she loves. I mean, it really, it's just a game changer. They come in the hospital, they have aortic stenosis, and then the next day, they go home and the next day they don't have aortic stenosis. They have a brand new valve. And so, if you are in that severe symptomatic range, this can dramatically, improve your quality of life and reduce symptoms. We're also looking, because as I mentioned, the big thing often is people don't think they have symptoms. Their symptoms are not recognized because their symptoms are just decreasing exercise tolerance. So they're just doing less and less and less, and they don't even realize that they've changed their whole lifespan, life activities related to this. So often when patients tell me, oh, I don't don't have symptoms and I can see on the echo the aortic stenosis is severe, I'll do probing questions like, well, what were you able to do like 1 year ago or 2 years ago? You know, what did you do at Thanksgiving last year compared to this Thanksgiving? And so often, you know, patients will realize, you know, I actually am doing less than I was. So sometimes the symptoms can be insidious because this is a slow progressive disease in most cases, and so people just kind of adapt to doing less and less. And so be thinking of that in mind when we think about symptoms. It's not always the, you know, chest pain, or it can be much more insidious, much more gradual.
And that's really important, I think, for all of us to recognize that, you know, it may start off just as tiredness, right? But then if that, you know, your fatigue is not normal to you, then that's something to really pay attention to and keep track of. Carissa, I know that Heart Valve Voice US has resources that are specific to the conversation we're having today. Can you tell us a little bit more about those?
Sure. So, in addition to our Ask for Echo campaign, we recently launched our patient ambassador program, and that really serves for patients to, of course, have a more empowered voice in raising awareness for bowel disease. Specifically, within that patient ambassadors, we really try to focus on making sure we're recruiting an equal amount of women into the program, especially since women are more likely to be diagnosed. Women are able to spread more awareness about heart valve disease and some of the risk factors within their own community. And hopefully, if they're hearing it from other women who have been through that similar journey, it can also trigger some alarm bells and other women who may be at risk to go get checked out as well. And of course, Heart Valve Disease Day is on Saturday. And we are partnering with the Alliance for Asian Research to raise awareness on some of the risk factors for valve disease. One of the key messages from the campaign this year is to listen to your heart and get screened for valve disease. So we're really trying to amplify that messaging to make sure that people are aware that even if your risk factors may just be, or symptoms may just be tiredness, shortness of breath, that's still worth getting that checked out as soon as possible. And last but not least, we are partnering with Rock from the Heart this year. They're hosting their annual benefit concert and awareness campaign as well as screening program in Minneapolis this year. And that's another way to get into the community on a grassroots level to reach people where they are and spread awareness of valve disease, whether that may be if they just are curious about it, they're experiencing symptoms, or newly diagnosed.
Thanks, Carissa. I'd like to bring Jody back on to talk about some of the resources that WomenHeart has. In addition to, I see there's a flurry of activity in the Q&A in the chat section. So feel free, Jody, to talk about what we have resource-wise, and then we can go in on the Q&A.
Yes, thank you so much, Selena. So I put some of the resources, and I'll put a couple more from Heart Valve Voice and from WomenHeart in chat, because so WomenHeart has its virtual Red Bags of Courage, where we have a bunch of resources. We have resources specific to heart valve disease. We also have more general resources about women and heart disease. We know a lot of things. You know, heart valve disease can lead to other diseases, as Dr. Michos has shared, like heart failure. And so we do have resources on those diseases as well. And I also shared, Chris, I shared your Heart Valve Voice patient stories, and I'll share a couple other resources in chat as well. The other thing WomenHeart has is our Heart Talks webinar series. And so WomenHeart has a YouTube channel, and you can find all sorts of fabulous webinars. This will be on there too. So you're going to find this on there, and the slides will be available as well. But you will be able to learn all about different types of heart disease. But not only that, but some of the other issues that go along with heart disease that impact women. And so those are available to you as well.
Thanks, Jody. So I see we've got a ton of questions coming through, and I know we only have a couple more minutes, but maybe if you can go ahead and share some of the questions out so that the panel can answer.
Yes. So one of the questions that I think, you know, I think you touched on this a little bit, Dr. Michos, but that is, I am a TAVR recipient for 5 years now. Can you talk about the lifespan of these devices and any new tech around replacements? yeah, concerned about the 2-time max. And so that is definitely a question that we see a lot, especially younger patients with aortic stenosis or who need a TAVR.
Yeah, so this is all things that patients will discuss with their heart valve team before they get the procedure in the first place. So this is a tissue valve, a bioprosthetic valve. It's not a mechanical valve. And so, it can wear out over time. So usually, they last at least 10 years, which is why in older adults, we almost always do the tissue valves because sometimes it lasts their lifespan, where younger adults, often that's not a good option because they have so many years ahead of them. There is a valve and valve procedure, so you can put a new TAVR inside of an old TAVR. So, sometimes when a TAVR does wear out and get calcified, sometimes they can get another TAVR placed in there. Risk factors for it causing to wear out, they wear out faster in younger adults than they do in older adults. And certainly all the things that cause degeneration of native valves can cause degeneration of TAVR. So smoking, high blood pressure, high cholesterol, inflammatory conditions. And so it's really important that all those cardiovascular risk factors are addressed to try to keep the valve healthy. But it's variable from person to person, and all those discussions happen before, with the valve team before the valve's implanted in the first place.
And there's a follow, thank you, Dr. Michos, and there's a follow-up to that in the chat for Crystal. So Crystal, the person said you look young, which you do, and so that's nice. And you were
I'm
50.
59 years old.
And you were 50 when you got to the diagnosis. And so what discussions did you have with your team regarding longevity of the valve, and what plans do you have for lifelong management of the valve that were discussed with your team? That's a great question.
I kind of figured till my TAVR wears out that there'll be something new or something different, that they'll replace it again, or I'll have to have surgery. I'm really not concerned about it. I'm just glad I had it done. And I thought I could be 10 years away, it could be 15 years away. And like I said, she just said they do have, you can put a TAVR inside a TAVR, which is a great thing.
Yeah. So in terms of the lifelong management, not just replacing the valve, I'm sorry, I'm just asking a follow-up to that. I apologize. What kinds of advice would you give to continue with that same question?
Um, Well, first of all, I don't smoke, I don't drink, I don't do any of that stuff. And like I said, my cholesterol is fantastic. Just try to live a healthy life and plan for the future, but don't worry about it. Just continue your life. And don't give up. Don't say, well, I lived a good life, it's over with. There's always improvement. And like I said, if I would have had to have it done 10 years ago, I would have had open heart surgery. But since I could wait till I was 68 years old, it was great. Or 69, I guess I had it done last October. I mean, everything went well, and I'm happy with it. I just hope it keeps working as good as it does.
I think the tip from Crystal is everyone should work on a farm.
Absolutely. It's good exercise, and certainly has probably kept you in good stead, Crystal. There are 2 questions in here, and I think this is, again, going back to Dr. Michos about different types of valve disease. So of course we're talking about focused on aortic stenosis here, but we have different people who are typing in questions about tricuspid valve regurgitation, and also and valve disease, and then mitral valve prolapse with severe regurgitation. And so I don't know, Dr. Michos, if you want to discuss that.
Yeah, I mean, just broadly, because we didn't have a lot of time, so I focused on one valve problem, which is very prevalent. But there's 4 heart valves. All valves can either, have risk for stenosis where they don't open, or a regurgitation. But often the symptoms, the same symptoms we're talking about, can be symptoms of any type of valve disorder. So paying attention to shortness of breath, or chest discomfort, signs of heart failure. This can be issues related to, mitral valve disease, not just aortic valve disease. And so the, determination if the valve needs to be replaced or repaired, again, goes to with the severity. A lot of times things that are mild to moderately leaking, we follow for a long time. Not everything needs to be replaced or right away, but it's important to be early diagnosis because there'll be follow-ups, often echo. Sometimes we do stress tests. We do other sort of catheterizations, other things to understand the severity related to the symptoms and then the findings. Now, unfortunately, there's a emerging area around this in terms of replacement for the other valves. We haven't gotten through transcatheter approaches as good of a replacement, not through these less invasive ways for the other valves in the aortic valve, because the aortic valve, where it's located and it's smaller, it's just a little bit easier to put a valve in for the stent. There is work in this area. There are catheter-based mitral valve replacements and even tricuspid valve replacements. Those are more challenging. Those are larger valves, and it's harder to replace them through a catheter approach. Those are more often still the standard of care is surgery if somebody's a surgery option, surgical candidate. But this is, again, something that the heart valve team will discuss for those types of valves when and if they do need to be repaired. But we don't have exactly the same level of equivalency as TAVR as we do with the other valves. It's just a little bit more challenging.
Thank you. We have, and so, and hopefully as those emerge, WomenHeart and I'm sure Heart Valve Voice will have more information coming out for you about that and patient education programs. There's a question about diagnosis, and, as you know, this is an area very important to getting treatment early for heart valve disease. This person said they are 29 and have a strong history of aortic stenosis, including in their family. And she is wondering, or he is wondering, are there procedures or checks that they can request from their doctor to get information about heart valve disease for them? Should they be asking certain questions or getting certain tests?
One thing I recommend everybody getting checked is a lipoprotein little a level, at least once in a lifetime. This is a particularly risky type of cholesterol that's linked with early heart disease and aortic stenosis, and it's very genetically determined. If it's normal, it doesn't need to be checked again, but just checking that once because there's new therapies in the pipeline specifically for that type of cholesterol. But anybody with a strong family history of aortic stenosis, I would get worried about bicuspid aortic valves can have a higher prevalence in families. And so if someone has a family history of aortic valve disease, I would get a screening echo in that individual, even if they weren't having symptoms, if they had a strong family history. And so they should, get an echo and probably a lipoprotein little a level. Now, we don't do sort of universal screening with echo in everybody, but I would have, certainly I would in someone who had a family history, and certainly I would with anybody with concerns, signs or symptoms that they might be having a heart valve problem. It always starts with a good history and physical exam. So that's the first step. And then anybody suspected to have a heart valve problem would get should be referred for an echocardiogram and ultrasound to actually look at the heart valves, by ultrasound.
Thank you. One person is asking, and I think this, Crystal, I think this is a question for you and both Dr. Michos, asking about exercise. This person has been read that you should not raise your heart rate to above 90. So, Crystal, did you have a conversation with your treating physicians about exercise? And for your specific case or exercise in general with heart valve disease? And then Dr. Michos, I would also think that's a question for you, are there some concerns about exercise that patients should discuss with their physicians?
Well, my heart doctor, he told me, do what I can, keep pushing, don't give up. You got to keep your heart strong. And he feels that's one of the reasons I went so long with it, because I do exercise. I mean, up until last year, I unloaded hay, like, wagons of 120 bales to throw in the elevator. I work. And like I said, I ride horses. I live on a hill. So every day I'm walking up and down hills, putting horses in and out. I have 8 horses. And he felt it was good that I kept doing what I do and kept exercising. He felt exercise was very important to keep doing.
Yeah, I agree. And we usually, if someone has a valve replacement, encourage them post-procedure to get into cardiac rehab, where, you know, in a structured exercise program, they can build back their functional tolerance and do exercise in a supervised fashion before they get the blessing to go do it on their own. But cardiac rehab is a very important part of recovery, whether it's a heart surgery or even after a TAVR. But exercise, you know, patients who do the, you know, best with surgery are people who don't go into surgery, you know, frail and deconditioned. So exercise is a very important part of this. So again, it depends, the issue is complicated. It depends on how severe the anatomy is. You know, there may be a theoretical case where somebody has critical aortic stenosis where we might say, you know, not to push it until we get the valve replaced, you know, but most patients, you know, who are in that, you know, range where we're following, we let them do their activities, because if they can't do those activities, maybe that's a sign that we should replace the valve. And then post procedure, we encourage them to get back to exercising and usually encourage cardiac rehab.
Selena, back to you. Thank you so much. Selena, back to you.
My goodness, thank you so much to our speakers. This was a really fruitful discussion. You guys, the engagement from the audience was amazing. I want to thank Dr. Michos and Crystal and Carissa and Jody for joining us on this really important topic. Please stay tuned for more from WomenHeart around heart valve disease. And we look forward to having you at our next Heart Talk. So thanks, everybody.